Thanks, guys, for having me. If any of you were here last year, it's a similar lecture, but I've updated some of the data and hopefully give you some more insights. Um, I show this slide here. My email's at the bottom. I always preface this. There's two Scott Robertses at Yale. So um, if you're trying to reach me for anything infectious disease related, bloodborne pathogen related, mine has the middle initial. Um, and so today, I really want to talk to you about how bloodborne pathogen occurs, transmission occurs, some of the major bloodborne pathogens and management strategies, and then hopefully give you guys, when you walk away from here, some tools about how, when you're in the operating field or even at the patient bedside, what can you do to protect yourselves against bloodborne pathogens in the workspace. But you're also required to be here by OSHA. So all employees must receive annual training on hazards associated with blood and other potentially infectious material. Um, so not only is this hopefully a helpful lecture, but it fulfills your OSHA requirement for annual training. So what are bloodborne pathogens? These are really any infectious agent in the blood and body fluid of an infected individual that can be passed from one person to another through contact with that human blood or body fluid. I think historically, this is where everybody is concerned, rightfully so, Hep B virus, Hep C virus, and HIV. But there's a whole host of other things that could be transmitted through the blood. And these are real things that have occurred. I'll give you an anecdote. I was consulting on a patient with babesia in the CTICU last year, and I noticed when I was going through his lab, somebody had sent a needle stick panel, and I said, "That's weird. This is a parasite babesia, which can be transmitted through blood transfusions." And I was like, I wonder if they realized that this guy had a positive babesia smear at the time. Um, uh, do they know that this is a potentially bloodborne pathogen? So I called the resident. They did not know, and so we were fortunately able to get that resident tested, who was negative. But to me, it spoke to the fact that we deal with many of these things in our health system. Patients you'll see whether here or abroad, but these could also occur. Transmission events could occur to healthcare workers through bloodborne pathogen transmission. Um, this was really one of the most notorious bloodborne pathogen transmission events. I believe this was an intern on one of her first shifts overnight when she was placing an A-line on a patient with uncontrolled HIV. She got stuck and ultimately acquired HIV, and led to this pretty major lawsuit. This was, in 1980 or the 1988. So right before protease inhibitors came about, and really at a time period when HIV was handled much differently than it is now. But because of events like this, many of what we have today in terms of our annual training, our education for you guys, safety measures we have in the OR derive from cases like these, where somebody was rushed on an overnight shift. We had old needle systems, processes weren't in place to protect this individual who ended up acquiring HIV from a patient. I'll give you a real case. This is a text I got from my friend. My wife's a third-year opto resident. She was finishing a case. She nicked her finger with a needle. It drew blood. What do we do? It's never that simple. The patient says he was treated for syphilis before. We checked an RPR, went from 1 to 1 to 1 to 4 now. Okay. Oh, by the way, my wife's 12 weeks pregnant. OC Health is closed. And so these are some of the questions we get. We need to think about many things. So first, was this an event that could have transmitted a bloodborne pathogen to that individual? So we need to classify that exposure risk. We need to classify, was the source patient transmissible? Did they have syphilis? Was it active? Was it to a degree and a level that could be sent? And then do we have a post-exposure prophylaxis mechanism in place? So can we give post-exposure syphilis penicillin to this individual? Is that safe in a baby? OC Health is closed. So these are some of the things that our team thinks about, and an example of cases we get where we really try to stratify, how infectious is the source patient, and are we not worried about just HIV, Hep B, Hep C? And then what do we do for that recipient who got stuck with the needle in the safest and cleanest way possible? Not just blood is infectious. Amniotic fluid is, I won't go down this whole list, but the bottom here is what OC Health really advises we say is any body fluid other than sweat could be potentially contagious. And this does not have to be needle stick injuries, but splash events to the eye in the OR, or really any splash of fluid to non-intact skin in you, we really want to know about. And we can do that risk assessment and make sure everything's okay, or if we do need to do any prophylaxis or any management strategies, evaluate it at that time. And these are the big three, really what everyone's concerned about. So Hep B, Hep C, HIV. I thought this graph on the right was good because it outlines all the healthcare workers who have been exposed to these pathogens. I believe this is an outdated study about 10 years ago, but it stratifies first contagiousness. So when we think about of these three, which is the most contagious, Hep B is by far the most contagious. And if somebody's not immune, about 1 out of 3 people will be infected with Hep B if they're exposed. Hep C, it's about 1 in 30 or 3%. And then HIV is much less contagious, so about 1 in 300 or 0.3%. So even if you got stuck with a needle of a patient who had uncontrolled HIV, the risk of you getting infected is still only 0.3%. This is still scenarios where we get you hooked up to go on post-exposure prophylaxis. But of the 1,500 HIV exposures, 0 healthcare worker transmissions have occurred. And exposure does not always lead to infection. So it depends on a lot of characteristics. So how viremic is the individual? Are they Hep B E antigen positive or E antigen negative? Is the healthcare worker Hep B vaccinated? So we take all this into account when we look at this, but of these three, Hep B is by far the most contagious. Fortunately, I believe you all are required to be Hep B vaccinated on onboarding, so the risk is really substantially reduced. Generally, bloodborne pathogen transmission occurs through one of 3 routes. The most common and most important is the first, so a skin puncture with a contaminated object. But there have been cases of number 2 and 3, so splashes or contact with broken or non-intact skin, and splashes or contact with the eyes, nose, or mouth, or the mucous membranes of an individual. I won't ask if any of you have been exposed to bloodborne pathogens, but I myself have. I was intern in the ICU doing a central line. I was trying to suture the line at the end of the case and stuck myself on an overnight shift. And when I finished, I realized I was trying to go through my head what happened, trying to replay the scenario. Did I get sick? Did I not get stuck? So I experienced all these things, and I was like, what do I do? I have no idea what to do. It wasn't at Yale. But these are real burdens that healthcare workers face when needle sticks do occur. Half have anxiety, insomnia, depression, anorexia, fatigue. A lot of people do self-blame. A lot of people reconsider their career choice, and that distress can at times often extend to family members. And so I'm going to go through this twice, once now and once at the end. So what do you do if you get stuck? So first, disengage from the activity in a safe manner. Wherever the area is where the bloodborne pathogen exposure occurred, wash that area with soap and water. The soap will really effectively kill a substantial amount of the viral particles at the site of the inoculation. Report to OC Health if it's during the daytime hours, but if it's in the ED, if it's after hours, I believe the only route would be the ED. We have communicated with the ED. We've also communicated with OC Health. And there are pathways in EPIC which kind of guide what they need to do. It basically says, is the source patient status known, or is this a needle stick and we don't know what that source patient had? That's pretty common. And so this gives a way so the ED could order labs on that patient. And if PEP is indicated or post-exposure prophylaxis is indicated, kind of go down that route. But make your supervisor aware of the injury. And then I don't believe we do this, but some actually have their supervisors escort them to occupational health. We or occupational health or the ED will do a medical evaluation. And this is really where we do our risk assessment. So, what happened? Was the source patient contagious with anything? Was it a hollow bore or a solid bore needle? Was PPE used or not? And if indicated, we will get lab testing in both the source patient and the recipient patient, as well as many other testing if indicated. And then if we need to, we can do post-exposure prophylaxis. So, we're now in an era where we're fortunate we have HIV antivirals that are very effective. We have Hep B vaccination, and we now have Hep C antivirals, which are also very effective. And then I showed this slide because HIV can actually reach the dendritic cell within 24 hours and ultimately be brought to the CD4 T cell in the regional lymph node by 48 hours. So we really have a 48-hour window if somebody's exposed to start someone on HIV post-exposure prophylaxis. And this is really the, one thing where we want to get somebody started on this ASAP, even if there's ambiguity in the case. These viruses, HIV, Hep B, Hep C, have up to 6-month incubation periods. So we may have more time than that, but we generally advise within 48 hours, you should have an evaluation if that patient is potentially HIV positive. There's been a handful of cases of post-exposure prophylactic failure in HIV. Most of these are before the current era of integrase inhibitors and triple therapy for antiretrovirals. So 16 cases occurred in the era of zidovudine, which is one of the first nucleoside reverse transcriptase inhibitors. And why did these people fail? We don't really know, but there's a lot of hypotheses. Some people think there was delays in starting the PEP, or the dosage was wrong, or the virus was resistant. Most HIV in the US is really very sensitive to most of our antiretrovirals that we do nowadays. And then, we've gone over a little bit of this, but what is the risk of HIV transmission? Transfusion is the highest risk, but take a look at needle stick injury, 0.3%. So again, 1 out of 300 chance, even if that patient is infected with HIV, that a transmission event would occur, which is only a little bit more risky than what we classically think, sexual intercourse or sexual-based transmission. Many states have laws. I once was I was treating a patient with HIV. I was in his room, and he said, but when I'd seen him on my own, can you not disclose my diagnosis to my partner? I rounded later in the day, and the partner was in the room. And, off the top of my head, I didn't think about it at all. I didn't disclose anything, but I talked to my team after the fact. I said, legally, how do we advise this partner they've been exposed to HIV? This was the patient's spouse. And per state law, we were unable to tell that patient directly, you have your husband has HIV. And so what we had to do was actually talk to the Department of Public Health, who ultimately calls the patient and says, you've been exposed to somebody with HIV. So there's a lot of state laws about disclosure of HIV diagnosis. It's required you obtain consent from that individual before testing for HIV. Now, if somebody does receive a needle stick injury, we can actually perform testing in an anonymous manner. So we do not need that patient's consent, or they can't say no, and we cannot get an HIV diagnosis to guide if you've been exposed. If somebody's exposed, we recommend checking an HIV antibody antigen test. The full Hep B panel that includes a surface antigen, a core IgM, and a total antibody, as well as surface antibodies to assess vaccine status, and then a Hep C antibody, which if positive will reflex to a Hep C PCR. What do? You should start post-exposure prophylaxis ASAP. We get pregnancy tests for women. The reason is dolutegravir can lead to neural tube deficits, and so it guides what treatment we decide to do for HIV. We do a 4-week, 28-day course, and we counsel, about half of people have pretty substantial GI side effects, so nausea, GI distress, and 50% do not complete the full 4-week therapy. We get an HIV test at baseline, 6 and 12 weeks, and then again at 6 months. And the reason for that is that the incubation period of these viruses can be so prolonged to the point where some transmission events have occurred, and they've been diagnosed, as late as 6 months after exposure. All right, any questions? Okay. I'm not sure if any of you have seen this study. I thought this was a very interesting study. I believe from the mid 2000s, which is interestingly authored. The senior author is Peter Pronovost, who is really the father of our bundled care in medicine. So, central lines, we generally have like a 5-step bundle. He actually created that at Hopkins. And then Interestingly, Martin Makary, who's the first author here, is going up to be FDA commissioner, I believe, next week. So he's gotten a lot of COVID-based notoriety. But these two guys authored this really groundbreaking study looking at needle stick injuries in healthcare workers. And they looked at surgical residents, and table one there, I believe this is cumulative data, but by the end of a PGY 5 year, residents with a needle stick injury was 99%, with an average of 7.7 needle sticks over the course of their residency. On the right-hand side here is any needle stick injury. You can see 99%. High risk, that means patients with HIV, Hep B, Hep C. By the end of residency, half of residents had been stuck in a needle with a patient who's had a bloodborne pathogen. So two-thirds of the time you stick yourself, 1/3 of the time, somebody else at the operative field ends up sticking you. Most of the time it's a solid bore needle as opposed to a hollow bore needle. Hollow bore needles are a little bit riskier because some of the virus can hide in the nooks and crannies of that hollow area. 72% of the time these occur in the OR, 20% of the time at bedside. What is the task which leads to this? Half the time it's suturing, which is where it was for myself. But generally it seems to be at the end of the case when people kind of start relaxing, try to finish up as soon as they can, and that's when the injuries occur. What was the perceived cause of the injury? 57% of the time the residents said they were rushed, 15% fatigued, 12% lack skills. Why don't people report? Well, 42% said it takes too much time. 28% said there's no utility in reporting, in spite of the fact that half of these residents got a needle stick from a patient with HIV, Hep B, Hep C. 6% did not want to know. 5%, there was a stigma of a needle stick. Who was aware of the needle stick? Half the time it was the attending, but half the time the attending did not know. 37% other residents, 34% a nurse, and then significant other was 13%. And these are presumably the people most at risk if a bloodborne pathogen transmission does occur, and you'd be exposing your significant other to it. Who doesn't report? Men don't report. So this was found to be 1.6 times more likely to not report if you're a man. If there was no involvement of a high-risk patient, you were 6 times more likely not to report. If it occurred in the operating room, you were more likely not to report. And then by far the most common variable associated with not reporting, you were 20 times more likely not to report if nobody else knew about it. So this is what we're up against. Okay, I'll go into a few data slides. This is just from the EpiNet showing that needle sticks are mostly among doctors and nurses. And for most of the time, the safety features are not activated at the time. For the body fluid exposures, 80% of body fluid exposures are to the head. So somebody didn't wear eye protection and there was a splash event in the OR, or they didn't know about it. And most of the time it's the eyes. And critically, when we say eye protection, I don't mean these safety goggles because there's a gap in the sides. And so we really recommend the full goggle, which covers the sides of the face, or a face shield, which goes over the whole front. 51% of injuries occurred during needle use, but 12% is between steps. And then 10% of injuries occur after you're done with the needle, but before you've disposed it into the sharps container. Suture needles and disposable syringes are really the most common devices. Most of these are the 24-25 gauge needles and insulin needles because they're so small and it's so easy to get the needle stick. Scalpel injuries are actually much less common. And then when they've looked at studies, what's your risk to actually convert to HIV? If it's a deeper needle stick injury as opposed to a superficial, that's about 15 times higher the risk. Visibly contaminated blood, placement of needles in veins or arteries, and then patients who were presumably much more viremic, I think intuitively makes a higher risk event since there's more virus there to inoculate. Where does needle stick injuries occur? These are the most common sites. It's usually the left index finger, the left middle finger, the left thumb. Less commonly on the right, and then the palms and thenar eminence is a much lower risk injury. This study actually found that the most common period for needle stick were the first 6 months of intern year. So a third of injuries are in the OR. Sharp tip suture needles cause most injuries. And it seems a lot of the time it's these deeper, it's these muscle and fascial closures is where we see most of the problems. Surgeons are the highest risk, scrub personnel 20%, anesthesiologists also get 6%. A lot of these exposures that they get are splash related, not necessarily needle stick. A few studies looked at surgical procedure characteristics and, what is higher risk, what is lower risk surgeries. This study found that the blood and body fluid exposure increased in patients with more blood loss when there's more people in the surgical field. And for this study, they looked at more than 15 or less than 15 members in the surgical field, and then procedure duration. So the longer the procedure, the higher the risk of a needle stick injury. And this study, again, showed the suture needle was really the highest risk needle on a regression analysis. This is similar data to prior, but really just showing the occupational group of those who were exposed. Attending physicians are actually the second most reported incidence of exposures. The most is a fellow or resident or student, which is by far the highest job title of who are likely to experience this. This was a interesting study done over 12 years, looking at changes in needle stick prevalence as well as protection practices and attitudes compared to 20 years before this study was done. First, it was a study done mostly in medical students, but some surgery staff, and 40% in this group experienced injuries, mostly in the OR. This to me was, there's actually a couple concerning slides that I found. I think half of the time in this study, they said that they felt careless or it was an accidental injury. 20%, similar to the prior study, the people were rushed. These are also similar, 30%, they were stuck by someone else in the operating field. And then 33% had at least one unreported needle stick injury. You can actually see the reasons up there for why they didn't. And again, inconvenience, no utility in reporting, stigma, these same themes are there kind of study over study. To me, as an infectious disease doc, this was really concerning to me. They actually had asked the people who were stuck with the needles, what do you think your risk was of getting a Hep B or Hep C or HIV? And the most common answer here was first, I don't know, in the far right. But the second most common on the far left was, quote, they believe the incidence was lower than than reality. And so what this says is that the perceived risk in people who do get stuck is much lower than that, than what it actually is. And so possibly that's some of the reasons why these events are downplayed. This study also looked at Hep B vaccination status. And concerningly, in 2003, there was a 99% Hep B vaccination status compliance. When they repeated the study in 2015, it had dropped to 78%. So I do believe that Yale requires a Hep B vaccination or proof of vaccination when you start here. But these are things that we really worry about, and we discuss a lot with occupational health about really making sure when you start work here at Yale, you're as protected as possible. And that's not just Hep B. We do check measles serology, for instance. So all of you should have documented immunity to measles before you start here. How do we prevent this? Double gloving, 79% of people always double glove. Most of the time, the medical students do it much more commonly than the fellows. 44% of people in this study said they don't feel there's a need. 79% wear eye protection, and then 80% receive the Hep B vaccine. So this was another study looking at some characteristics of needle stick injury. The novel things here was that wound closure was the most common source of where these injuries occur. And then in this study, they also found that trauma cases were much more common than non-trauma cases as a risk for needle stick injury. So it does seem to be those, more complex, longer case patients where usually during wound closure. Some more data here showing solid needles are most common in this study. And then the bottom table here really showing factors affecting reporting, again, patient communicable disease status. So if the patient is negative or they're HIV, Hep B, Hep C negative, that is the factor where the resident is most likely not to report that. And I did give that example where there's many things besides HIV, Hep B, Hep C. So if you do get a needle stick, even if somebody is negative, we still want to know about it just to do that risk exposure and risk classification. Here's some factors. I think this study looked at instrument factors. So lack of safety devices, failure of safety devices, type of instrument, and type of needle. So these are all things that we periodically review with ACHEL to make sure that we are giving you guys the safest equipment possible to do the surgery. And then environmental factors, so emergent cases, unstable patients, longer cases, and then evening and night procedures are higher risk than routine daytime procedures. So there's a lot of strategies about what you can do in the operating room to reduce this risk. There's alternative to sharps when at all possible. We advise these be done, such as staples, cauteries. The safety devices we review, we prefer the retractable needles and retractable scalpel blades rather than needing to be capped, which is a much higher risk needle. We always advise there's a neutral zone that's predetermined, so some dedicated space, if possible, where instruments could be passed. Double gloving, protective face wear, such as goggles and a face shield. We do many things before. We really try to reduce the risk as much as possible before that risk reaches the operating room. So do we have sharps bins in the room that are visible? Are we doing the right devices before the case that are given to you guys to reduce that risk? Is PPE outside the room? Do we have a system in place to report if a needle stick injury does occur? So there's a lot of stuff that goes into this actually before these occur. A lot of this was really started in the 80s with OSHA, with what's called universal precautions. And then this has really morphed into what we now call standard precautions. And these are what the CDC advises you guys do for every patient you see, kind of regardless of what they have. So perform hand hygiene, use PPE if indicated, respiratory hygiene, cough etiquette. And I think what they're getting at here is don't come to work if you're sick, for example. Ensure healthcare worker safety through proper handling of sharps, safe injection practices, sterile instruments, and then cleaning and disinfecting the environment. Talk through some of this. Some safe sharp practices. So never bend, break, or recap needles. And we, again, advise, we really try to get you only the right needles that you don't have to recap or that you can just press a button and they retract. Never remove the needles from a syringe or blades from a scalpel by hand. Use the sharps container. I'm not sure how frequently this occurs, but it's really advised to not let that sharps container overfill. So we advise the EVS teams to, when they're 3/4 full, at that point, the sharps container should be discarded and go back to zero. And then never reach inside or force items in a sharps container. And then we've talked about this, but a lot of injuries occur during disposal of sharps and at end of cases. These are some devices that that are good in the fact that, it's either a single button where it retracts, or they cap very easily, or, your butterfly needle where you don't have to think about it. You press a button and then all of a sudden that needle is gone. So whatever we can do to reduce the risk of operator error, I think keys would be just in no circumstance would somebody want to try to recap that needle or re-put a cap on something like a scalpel blade after it's already been opened. Some safe hand hygiene practices. We really recommend hand hygiene, which is either hand washing or using the alcohol-based hand sanitizing gel or Purell before touching patients, before putting on gloves, before procedures, between body sites. So if you do have to inspect a clean area of the body versus a surgical wound, it's recommended you don't cross-contaminate on that patient. After touching a patient, after touching the environment, after handling dirty equipment, before eating and drinking and using toilets. We monitor hand hygiene. So you may have seen our team around, but periodically we are required to do 200 observations per unit. This is a metric that we report to Leapfrog, Envisian, and many value-based purchasing organizations. So we may have people, secret shoppers, but they're on the floors, you don't know who they are, and they're really looking to see who's doing hand hygiene. Anybody guess how frequently Yale healthcare workers do hand hygiene on average before it going in patient rooms?
50%.
It's about 70%. So definitely not 100. Some units are in the 90s, and some units are well below 70%. So yeah.
If we have two patient rooms that are like right next to each other, do we necessarily have to
wash our hands after we leave the room and then wash our hands again before we go into the next room? Or
Yeah, it's recommended you do, just because we don't know what that patient could have. And so, I'll go through this, but examples include C. diff, where these are, really transmitted by fomites. And so if somebody has it, the way to get rid of it would be to washing hands. The challenge we have is that we don't know a lot of these patients. We don't know who has C. diff or who doesn't, oftentimes until they've been admitted for a week, for example. And so that's some of the reason why we recommend that. But for most patients, you can use the Purell. So you just go outside the room, get the Purell. It has an automated amount to cover your hands fully, hopefully, or you could use soap and water. Either are really sufficient. Yep.
I think maybe I'm thinking about the same question as Ankar's, but like if there's a patient in this room and the next room, and you go into this room, Purell, you go into the room, you come out, you Purell, and then you could just go into the next room. You don't need to.
Oh, I see what you're saying. Yeah. Correct. Yeah. So you just want to ensure that before seeing and after seeing every patient, there's a new event, a new hand hygiene event. So you leave the room, you do hand hygiene, and then go off, do whatever. When you go in that next patient's room, you just want to make sure you've done hand hygiene before you go into that. Soap and water is actually better than the Purell. The reasons is that soap and water kills spores. And so C. diff, norovirus, noro's a non-enveloped RNA virus, which lives on surfaces for weeks. So these things Purell will not kill. And so for that reason, hand washing with soap and water is better. This is from the WHO. You actually need to rub your hands for 15 to 20 seconds. I don't know if anyone's ever done that, but that's certainly the recommended process. And so where do people miss hand hygiene? The fingertips, the webbed spaces between the hands, the palms, and then the thumb is really where what's most commonly missed. When should you not do Purell? So I mentioned C. diff, I mentioned norovirus. The other example is when the hands are visibly soiled or come in contact with some body fluid or blood. In this case, to be safe, we recommend soap and water. Don't even mess with the Purell if that occurs. These are our signs. So the right-hand sign, this is contact plus. We'll put any patient in C. diff or norovirus or, any kind of drug-resistant pathogen may go in this contact plus sign. When you see this, it's recommended to do soap and water, gown and gloves, and then take a look at what disinfectants required. So this is we at Yale, we have the purple top wipes, and the orange top wipes. The purple top wipes are quaternary ammonium. So that's sort of like isopropyl alcohol, where it's like Lysol. It'll kill all your bread and butter stuff, but not your really significant stuff. If you're really worried, then the orange top, this is bleach or sodium hypochlorite. This will kill your MDR pathogens, your Candida auris, your C. diff, and your norovirus. And so when in doubt, the bleach is a superior wipe to killing pathogens. The problem is it will degrade equipment. So, and the other problem with these wipes, if you actually read the label, do you know how long your stethoscope or your reusable device has to be wet with this wipe before it's disinfected?
15 seconds.
For isopropyl alcohol, it's 15 seconds. Unfortunately, these wipes are mixed with quat ammonium compounds, so it's 4 minutes. So a 4-minute wet time. I don't think anyone's ever sat there and kept their stethoscope wet for 4. And we've actually looked at this. It dries out after about a minute. So if you do cover it and disinfect it, per their manufacturer, you really need to do it 4 times before it's fully disinfected. That's probably an overestimate. I think intuitively, when you wipe these wipes on things, most things will be killed because the inoculums that we've tested, millions of bacteria and they're still effective. And most of the time when you do have a stethoscope after a patient, there's probably about 20 colonies of bacteria on that stethoscope, so much less quantity. So PPE, these really protect you. I think PPE after COVID really came about. We are in a much better supply situation now than we were in COVID, if anybody was working during that time. But we have ample supply of all types of PPE. So take a look at that sign and you can it tells you what you need. if this were a COVID sign, it would say special respiratory precautions and there'd be a respirator on there. So when in doubt, look at the sign at the top of the room and see what you need for that patient. It's recommended to glove when you anticipate contact with something, blood, saliva, mucous membranes, and then you can remove the gloves after patient care and do hand hygiene. And then if you do anticipate that, use a new set of gloves for each patient. Really don't use the same glove. And then at the bottom, gloves are not a substitute for hand hygiene. So this is our secret shoppers. This is one of the reasons why we find, somebody puts on gloves, they think they're fine, but we really need that added disinfectant step to kill what was on the prior patient on your hand. And then, other reasons why people don't do it. The most common one is people are carrying something into the room. So, carrying a food tray into that patient, and they're not going to put it down and go wash their hands, even though we do advise that. Gowns should be tied at the waist and the neck. So if you guys do take the gowns, I've certainly not done the neck, and I've had my gown drape over the patient, so I think we try to purchase gowns that require both, just so it can be sturdy. Surgical masks and eye protection with solid side shields if there's anticipated splashing events. And then some PPE can be reused. So, face shields, goggles, for example, these can either be worn throughout the day or they can be taken off and then disinfected with that purple top wipe and then used for the next patient. This was a really big deal during COVID when people had to reuse PPE patient to patient. But you can actually, keep, there's many different types of masks. There's surgical masks, there's non-surgical masks. A lot of these depend on how durable how many layers are in the mask that covers your face. Surgical masks specifically, the ones that you guys have in the OR, are actually higher grade and splash resistant, or supposedly more waterproof than the masks that are on the floors. Sharps, an example of a sharps container, really any infectious waste should go in this. So even if it's not blood, CSF, pleural, peritoneal fluids, there should be dedicated biohazard containers that are accessible, as well as, bins and whatnot on each unit where if you do have biohazard waste, you have blood, they can be discarded. I'll skip through some of this. Needle safety device characteristics. So safety features are really integral. Device works passively. You guys can tell if it's an activated or non-activated device. And we periodically review this. So if you're in a case and you say, hey, this device is awful, I can't retract it, or it's not doing what it's supposed to do, we do want to know about that. So let us know when we can review these things. So another event does not happen. There's been a few laws that have addressed this. One, before the passing of this Needle Stick Safety and Prevention Act, needle stick injury was much more common in healthcare. And after this act was placed, the rates substantially decreased. And so we now follow a lot of the guidance that was given in this Needle Stick and Sharps Injury Act, including this annual training. And so when this occurs, we really try to maximize how safe these healthcare work environments can be for you guys. I thought this was an interesting study. They looked at how important is your team to needle stick injuries. And they had this study use something called the Team Stability Index. And I believe what they did here is they kept the same surgical team for 6 months and then they switched. And when you did that, you actually reduced your needle stick injuries quite substantially. So I realize that is not a possible thing when you're in an academic environment and you're rotating between cases. But in many certain settings where it can be done, a greater team stability of personnel lowers that risk, because you know where people stand, you know who's going to do what part of the case. And the impact here was felt most in devices other than suture needles, which historically is the most common. Yep, I'll pass through this. So I'll just close, just a few slides of review and then close. So what can you do? So avoid use of needles when there's alternatives, such as electrocautery or stapling. Get involved in selecting these devices. We do periodically review this with OC Health. Use the safety mechanisms. Don't recap. Safe handling and disposable. So, make sure every OR has a sharps container. If it doesn't, we want to know about that. Dispose of them in appropriate containers. Report all injuries. Report observed hazards from sharps. And then bloodborne pathogen training. And so that includes, you guys are all up to date on vaccines. We advise hand hygiene, PPE. Really, my goal is to make you guys as safe as possible when you're out there. And this is, just a quote here, quote, "The largest percentage of all sharps injuries occurred in the OR with the greatest numbers among physicians." So infection prevention starts with, is everyone's responsibility, but safety starts with you. So I want to review one more time what you do if you get a needle stick. So first, recognize you did get stuck. Clean the site with soap and water. So take off the glove, douse the wound with soap, notify your supervisor, which during the daytime is going to be occupational health. And I'll show you their number in a second. After hours is going to be the ED. Perform a risk assessment. That's our job. So we assess what did that patient have? Did they have any? Do we know about it or not? Can we order labs on that source patient? Do you need post-exposure prophylaxis? And if so, we treat you. And then we counsel you and we see you in follow-up. And so we'll get you plugged in with occupational health. There is Occ Health here at Yale. I believe it's the Yale Employee Health Center. There's an after hours number. There's an ER number, the 203-688-2222. I'm not sure if you guys know pathways, but if you actually go into Epic, any patient pathway, there's a specific blood and body fluid exposure needle stick injury pathway. And so, let's say you, for whatever reason, you don't want to report or you think there's low risk, which I don't advise. We want to know about every needle stick. The guidance that we give the ED physicians and Occ Health is in this pathway. And so you can actually look, and here's the contact numbers for each site if you're rotating at a non-YNHH site. And it tells you what to do. So examples are here. High risk, order these labs in the patient, order these labs in you, and we ultimately get you plugged in with Occ Health.